Okay, why don't we go ahead and get started? Does that sound okay to everyone? Um,
Yes.
Lovely. So I am Margaret Crone. I am the director of the Maryland Physician Health Program here at the Center for Healthy Maryland, which is part of MedChi. I want to thank everybody for being here this evening. I especially want to thank our speaker for taking the time to be here and to prepare this great talk for us. Um, I also want everybody to know that this, in case you didn't know, is our 45th anniversary of MPHP. We're celebrating all year. We have this lecture series, which is entitled Lemons to Lemonade, Harnessing Our Strengths in Difficult Times. Um, Dr. Harkavy Friedman is, I believe, our fifth speaker so far. And we will be having a great talk in October. Dr. Wazinowitz is kind of in charge of that. It'll be a panel discussion we're really looking forward to. So anybody on this particular lecture will definitely get notice of that lecture when it comes up. So please, please, please join us and tune in. And that is, I believe, October the 11th. It's a Wednesday. I also want to let everybody know that we are a nonprofit. We do really appreciate the support of folks in the community. If you feel that you can make a donation to keep things going for the MPHP so that we can expand programs, provide services for folks that have a hard time paying. Some of the folks that come to our programs actually are not working because of some of the issues that bring them to the program. So if anyone can donate, we'd be so very happy. Just a mention about questions. You may have questions or comments during this talk. If you could please save those to the end, feel free to put them in the chat so you won't forget what your question is. And at the end of the talk, I will be reading those questions out. Or if you just want to raise your hand or just say, hey, I've got a question at the end, then that would be great. So next, I want to turn this over to Dr. Marty Rusinowitz, who is going to introduce our speaker.
Thank you, Margaret. It is a real pleasure and honor to introduce Dr. Jill Harkavy Friedman. She's the Senior Vice President of Research and leads the American Foundation for Suicide Prevention's research program, which funds research grants, offers workshops and training to researchers, and disseminates research findings to increase public awareness and support advocacy. Over the past 35 years of experience as a clinician and a researcher, she has published over 100 peer-reviewed articles and trained clinicians around the world. Jill has earned her BA in psychology at the University of Pennsylvania and her PhD in clinical psychology at the University of Florida. She completed her internship at Yale New Haven Hospital, and she joined the Montefiore Medical Center, Albert Einstein College of Medicine, establishing the Adolescent Depression and Suicide Program. In 1989, she moved to Columbia University, New York State Psychiatric Institute, where she is an associate professor in the Department of Psychiatry. She joined the staff of AFSP in 2011. She maintains a clinical practice in Manhattan. In addition to the formal bio, I was looking at Jill's CV, which is 18 pages long, most of it her bibliography. It's quite incredible. And this is such a somber subject that I was very happy to see. Tom Allen pointed out to me that on the last page under other activities, it says Chair Comedy Night, Center for Hearing and Communications. So it's nice to see the diversity in one person, and I hope this is as enjoyable and as that might be. So Jill, it's all yours. Thank you.
Oh, thank you so much. It's truly a pleasure and an honor to be here. And it's kind of fun to have my comedy night event noted in this talk. I like to laugh, whether it's comedy night or while this is a somber and serious topic. I find that the work in this area is actually quite uplifting because we can have the impact of helping people, whether it's people who are thinking about suicide or have lost someone to suicide, and also taking care of ourselves, because I think sometimes we give so much we forget to pay attention. So I'm hoping that some of what I talk about is going to be a review and remind you that we all need to take care of ourselves. So, in terms of disclosures, nobody's giving me any extra money besides AFSP, although I do consult with many organizations about research and methodology. Tonight, the goal, as I said on the flyer, is first of all to explain a model for understanding suicide, enumerate risk factors and warning signs for suicide, list resources and actions to prevent suicidal behavior, and describe ways to maintain mental health and well-being. And I look forward to sharing this because I think of this as something that's important for our patients, but also for ourselves. So the focus on all of this is kind of universal. And anyway, I like to show this picture because I believe we are inherently motivated to be productive and engaged. And the building of sandcastles, I think, is the best evidence of that, because we build them knowing that they're going to be washed away. And people spend all day building them. It's a communal activity usually. People don't do it on their own. And I raise this because when people aren't being productive and engaged and progressing, it's typically a sign that something's not working. It doesn't necessarily mean they have a mental health condition. They may just not feel that well. But it's a sign that we ought to check in with them.
Jill, I don't want to interrupt you, but the slides are not progressing. Am I the only?
Yeah, no.
Yeah, I was just going to say. Yeah.
Okay, now,
Yeah, I don't see it either.
Oh, for some reason it keeps stopping. Okay, I got it. There's my disclosures, not much. Here are this was actually on the flyer, my objectives for tonight. And then this is the picture of the sandcastles, which is always fun to see. But I'm going to make some assumptions for tonight to frame what I'm talking about. And the first assumption is that we all have mental health. Sometimes I ask this in a group, who has mental health? And people kind of look around like, do I have mental health or don't I? But we all have mental health. And sometimes we feel well, sometimes not so well. And sometimes we have a mental health condition that we need to take care of. And the second assumption I'm going to make is that health is physical and mental health combined, and that physical and mental health are synergistic. They're not distinct, but there's a whole person, whole body. The brain is an organ, but our bodies and our minds are affected by our environment, by our social functioning, by the food we eat. So it's one sense of health. And people sometimes forget this, or they only think about one or the other. But our mental health and physical health are intertwined. That our health impacts our social well-being with family, friends, and work. And in fact, that's why we're here tonight, to talk about taking care of our own mental health along with the mental health of our patients and also our loved ones. That taking care of your mental health overrides everything. That if you are not feeling well, you can't function as well. And so it's time to stop and take care of our own mental health. And it doesn't mean that it's lifelong. It could be just in the moment, but it's something we must do. It's an imperative if we want to have rich and full lives. Then the last thing is, you are not alone if you need help. And the medical community has kind of, in the past, made it quite difficult for medical professionals to seek help for fear of losing your licenses and things like that. But that's actually changing, and many medical centers are providing access to mental health care to clinicians within the system. So this is all changing, and that's a good thing. Also, well-being affects our patient care, right? So if we take care of our own health, we're going to provide better care to others. We're less likely to make errors. We're also less likely to leave the profession because of burnout or discouragement. The habits that we practice to promote well-being and resilience need to be cultivated. It's not always, I know I said the sandcastle thing, but that's when you're feeling healthy. But we actually have to be mindful and make plans to take care of our mental health throughout all stages of our career. And it's a shared responsibility that we help each other take care of our mental health. I know when I was a young clinician and researcher, which I was told you can't be both, but apparently that's not true. When I was having kids, there were certain issues that came up for my work, for my well-being. When my kids were grown, other issues came up, but I became a source for other young women who were coming up in their profession who wondered how they could do work and raise a family. So we help each other. It's a shared responsibility. And that a healthy professional culture, which we create, will lead to improved healthcare for all, both providers and patients. And this sounds very basic, but sometimes we forget. So if you're in a situation where that's not happening, I just want to raise awareness about that. There have been more national initiatives to help prevent burnout and to take care of mental health and address suicide risk, like I said. So these are some of the medical organizations that have begun to do that, and they have resources if you want to go to them. At the end, I have a list of resources, but I'm not going to share them. But when I send you the PDF, they will be available to you. Okay. So, for a long time, especially mental health clinicians and physicians didn't talk about their mental health at all. It was something that was hidden. Not that there weren't mental health problems, but it was something that was hidden, was a secret. Maybe you didn't even tell your family because you were worried about your reputation and your practice and all of that. But in just an example, in July of 2020, a physician who had 136,000 followers disclosed on social media that they had mental health condition and they were in mental health treatment. And over 500 healthcare professionals shared their similar stories. So it's been a hidden secret that that healthcare professionals actually have mental health, and we have to take care of it, that we might have mental health conditions, and we need to talk to each other. So what is caring for your mental health involve? And I'm going to say more about this later, but first of all, attending to the basics. Think about yourself. Are you sleeping? Are you eating well? Are you exercising? I'm not very good on the exercise part myself. I find other things to do besides that. Are you showering and grooming and taking care of your hygiene? Do you have problem-solving skills, or do you need to develop more skills? Things change. Many of us are older. For example, technology. If you don't know how to use technology and you find it stressful, take a course. Have your grandchild help you, but learn it so that instead of becoming a stress, it becomes a source of pride and also productivity. Practice your coping skills. People keep asking, what do I have to do to cope? And they forget that there's stress relief and then there's coping. Coping is problem solving, which you can't do if you don't relieve some of the stress. And there are many different coping strategies that people use. I'm sure you work with your patients to help them develop coping strategies. Well, we need to do the same, and we need to do it we need to upgrade our coping skills based on where we are in our life, based on where we are in our careers, based on all kinds of things. If you're new to the field, if you're thinking of retiring, those are all periods that bring new challenges. And so we also have to fostering cultural and religious identity. Having a strong identity is key to feeling well, to functioning well, and to suicide prevention. It turns out having a strong identity and if you're in an underrepresented or minoritized population, this is particularly important. Having social supports and community connectedness. Wherever you get that, it could be in, at your religious sanctuary, or it could be at your pottery class. It could be at the grocery store, but making sure that you have social support and community connections. I'm going to say more about how that affects suicide prevention. Reaching out to trusted friends and family. More and more people are talking about their mental health, but the truth is, while most of us would help somebody if they had a mental health problem or suicide risk, we don't tell people. We have to get better at letting people know, because when you're in that state, it's hard to reach out. So reaching out also means if you're worried about someone, reach out to them. It's hard when you're not feeling well, push yourself to do it. But if you're worried about someone, that worry can weigh on you. And maintain a positive attitude toward mental health treatment. A lot of mental health providers don't get mental health treatment when they need it. And that's something that's very critical. And so we need to seek help when we need it. How do you know when someone's not feeling well? I'm going to talk later about how do you know when somebody's at increased risk for suicide. But, their mood changes. Maybe they're withdrawn. Maybe they're irritable. Maybe they're overwhelmed all the time. If they have changes in sleep or eating or activity, they look exhausted. All of a sudden, they've put on or taken off a lot of weight. They're not doing things because they're sitting on the couch. They're pulling back from events. They're not talking. Also, less productive at work. Maybe they don't show up to work. Maybe they're late all the time. All of a sudden, they're late for their patients. Like if you notice yourself or someone else having these things, it's a time to do a mental health check. And also, of course, increased drinking or use of substances. So now I would like to talk about suicide and understanding suicide and how it works. So the one thing that's really important is how we talk about suicide. When we talk about it with our patients, our family, and our friends. And, the olden days, people used to say that somebody committed suicide. And that it actually comes from the fact that it was a crime. And it still is a crime in some countries, but it's not a crime in the United States and most places in the world. So if you say to someone who lost someone to suicide, oh, your son committed suicide, that's very painful for the person who lost someone. Suicide is the result of a health condition. And so just like other health conditions, we say died by suicide. The other day, somebody brought up the idea of saying died of suicide. So we'll see if that will also work, because you say died of a heart attack, died of cancer. But the point is they died by suicide. They didn't commit a crime. It's okay to say they ended their life or they killed themselves. Those are also, the problem is that they imply a level of decision-making that's not really there for a person who's in a crisis moment. Again, we'll talk more about that. The other thing is you're not rated on your suicide behavior. So, we don't call an attempt successful because that means you died, or an attempt was unsuccessful and you failed because you lived, right? So we need to start reframing how we talk about it. These words have an impact. Imagine people saying to someone, oh, so you made a suicide attempt and it failed. How do you feel about that? What do you think they're going to say to you? Not much, because you've just put them down and not understanding that they have a health condition. The other thing is there's never one cause of suicide. And as people, we're always trying to find one cause. We tend to categorize. So you see in the news, or you see people say, oh, they died by suicide because their relationship broke up. They lost their job. Well, what I want to say to you is that, first of all, it's never one thing. And also the thing we see, the stressor, is never the cause, but it could facilitate a suicide attempt or suicide in a person who's at risk. So we see this event and, you may work with the loss survivor who comes in and they say, my daughter died because her boyfriend broke up with her. But if that were the case, most of us have had a breakup of a relationship. We do not think of killing ourselves. But it can precipitate it because in the background, there are these biological, psychological, social, and environmental factors that are always interacting. So let's say you talk about mental health, right? Well, sometimes you're in an episode, sometimes you're not. Mental health conditions have biological, psychological, social, and environmental aspects to them. And maybe you're sick, and so your depression is worse. Or maybe you lost your job, and so psychologically, you feel like a failure. So all these factors are happening in the background. So you have these factors that increase vulnerability, and then the stressor. And then if you have access to lethal means, there's a good chance you will die if you make an attempt. So there's those three factors: vulnerability, stressor, and lethal means. We can intervene in any of those spaces as clinicians. We can treat conditions that people have. We can help repair environmental. We can deal with trauma and abuse so that it's not having the same negative impact. We can't get rid of the trauma that happened for people, but we can help them put it in a place in their life so that it's not affecting their entire being. So we can intervene there. We can intervene in helping people cope with stress. But we have to remember that it's perceived stress because, there was a student who failed a test and killed himself. That doesn't seem like a very big stress, but to him in that moment, the way his brain was thinking, in combination with risk factors and the fact that he had access to lethal means, he didn't make it through that crisis. And what we know is if people can make it through the crisis, they most likely will not go on to make another attempt. And if they do, and we limit access to lethal means, even if they make an attempt, they won't die from what they did. So there are many contributors that I talked about. So having a chronic illness, having chronic pain. 90% of people who die by suicide have a mental health condition, diagnosable and potentially treatable, but they don't necessarily know that they have it. And that's why public education is so important, why going to primary care, people who are educated, is so important. Also, they may have they may lack problem-solving skills. They may have had early trauma. ACEs are finally getting some notice that they are really bad for you to have adverse childhood events. The reason why head trauma is another one. Family history of suicide is another one. Substance use is another one. The reason why I'm listing these off is because if you do a full evaluation when somebody comes to your office, you will know what their risk factors are. You can learn through an intake exam, a thorough one that looks at health, social functioning, family history, etc., medical history. You should know about from that evaluation what the person's risk factors are. But one of the things that we also look for is cognitive inflexibility. So the parts of the brain that are affected, and I know we could go down the path of talking about the parts of the brain and brain function and neurotransmitters and hormones and all of that, but I'm not going to do that. The thing that we need to look for, and you can see it in patients, is when they have that difficulty shifting gears. They have that difficulty problem solving, and they can't see the options. They feel pain. Most people who die by suicide don't want to die. They just want to stop the pain. And we've learned from research that emotional and physical pain have very similar, if not the same, neurophysiological pathways. They feel hopeless. Nothing's ever going to change. They feel desperate. There's nothing they can do. Now, the truth is, there is hope, and there are many things they can do. But in that moment, particularly in a crisis moment, they don't have access to their usual coping. So it's really important to look for that cognitive rigidity, that cognitive inflexibility. During a crisis, like I said, the person doesn't have access to their usual coping. That's how families can say they always functioned so high and they were doing so well. They were great at problem solving, but in that crisis moment, they don't have access to it. They feel they have what I call a disconnection, dysfunctional connection, not a DIS connection, not a not being connected, but they can say, I love my family. My family loves me, but they'll be better off without me. I'm just a burden to them. So they're very connected. So if you're looking for them to not care about anyone, that can happen, but a lot of times it doesn't. And feeling like a burden and that your family will be better off without you is not uncommon. So look for that disconnection and their sense of purpose. What do we hear? What's the point? I have no future. Nothing's ever going to change. And as I said, their intention is usually just to end the pain, not necessarily to die. And we know for people who've made serious, nearly lethal suicide attempts that they desperately want somebody to connect with them. They're not thinking about you. They're not thinking about their therapist. They're not thinking about their family. They're not thinking about their friends. They're thinking about, how do I stop this pain? But if you can give some time by removing access to lethal means, for example, between that crisis moment and action, they actually, it's an arc. There's an increasing crescendo, and then the distress starts to dissipate. Doesn't mean they're going to be fine afterwards. It doesn't mean like they're not at risk. But if we get them through those crisis moments, which involves enlisting family and friends as well, the likelihood is that they will survive. So that's, if you see that kind of thinking happening. And sometimes, by the way, you hear that a year before. The problem is people don't say, okay, now I'm going to do it. I know I've been talking about it for a long time, but now I'm going to do it. Most often it happens in the moment. So we can't just rely on trying to predict who's going to do it and who's not. We have to help people develop the skills. So what are warning signs? Is what people say, what they do, and how they feel. They will literally at some point joke about or say something about ending their lives. Oh, or you won't have to worry about this next year. They don't add, because I won't be around. It doesn't really matter. Or I'm a burden, or I just can't take it anymore. 75% of people who die by suicide told somebody within the few months before they died that they were thinking of taking their life. Take it seriously. The worst that could happen is you'll be wrong and you'll help them develop some new skills. In terms of behavior, increased use of alcohol or drugs, issues with sleep. Insomnia is a big marker for suicide, but other problems with sleep, such as, trouble falling asleep, waking up in the middle of the night, getting up super early in the morning, withdrawing from activities, isolating from family and friends, looking for ways to kill themselves, which people do on the web all the time. There's sadly evidence on their online searches a lot of times that they were looking for ways to kill themselves. And also on social media, when people die by suicide and you go back over their social media, you see it there. You see all these things. Giving away possessions. It's a way of making sure that people have, that they're, I don't know what it is, but they start to give away their possessions because they're assuming they're not going to be around anymore. And they thought this was important to you. Or we had one person who talked about telling his parents that they did a good job. I used to joke that when my kids all of a sudden told me I did a good job, and I was like, oh no, I hope they're not suicidal, but they just really thought I was doing a good job. But honestly, telling their therapist, I've learned so much from you and I've gained so much and I appreciate you. If there's no reason for them to say it that day, think about that. Go over your checklist of risk factors. Check whether or not you've seen other signs. And then the last thing is mood. We always think of depression, and about 60% of people who die by suicide have major depression or bipolar depression. But you'll also see apathy, rage, irritability, impulsivity. Humiliation is a big one. Feeling shame which is really outward facing, what others will think of you. Because when someone's humiliated and they have cognitive inflexibility, they feel like nobody's ever going to forgive them or forget the stupid thing that they did. And anxiety. But anxiety is usually accompanied by other symptoms. Just like with PTSD, the most common disorders, comorbid disorders for people who die by suicide are depression, psychosis, and substance use. If you look at eating disorders, depression, psychosis, or substance use. So there's something about those disorders that can lead to some of the dissipation. But if you treat the mental health condition without addressing the suicidal behavior, you might prevent suicide, but you have a better bet if you, first of all, work with them to have a safety plan, and then use either dialectical behavior therapy, CBT for suicide prevention, appropriate medications, antidepressants, for instance. Nobody died in any of those studies that led to the black box warning, FYI. The warning is you may increase ideation. Antidepressants are great for helping to reduce suicide, but also ECT and lithium, those have a lot of data behind them. We don't use lithium, but in fact, it's very effective for suicide prevention. So these are the warning signs, but again, they happen sometimes gradually over time. Or they could happen that somebody comes into your office or a family member calls in a panic. So we can't just look for these things. We have to have that who might be at risk understanding of our patients. If you have any sense that something's not, that somebody is not in a great place and they may be at risk, trust your gut. And the most important thing is to ask them. You will not make somebody suicidal by asking about it, but in fact, you will bring most likely relief. In addition, you might miss the opportunity of saving someone's life by not asking. There's lots of research that shows that, again, asking someone about suicide, are you thinking of taking your life? Are you feeling so bad that you want to end it all? Is not going to make them feel badly. And if they say yes, it doesn't mean you have to hospitalize them. It means you have to have a conversation to find out what they're thinking and get a better sense of where they're at. Highest risk for suicide is after hospitalization. So hospitalization is for somebody who is an immediate risk, who needs to be in a safe environment, or somebody who needs, for instance, they're psychotic and they need their medications started. But the period after hospitalization is a high risk period. And most suicidal crises dissipate if we have a conversation, if we gather the supports, and if we have a plan for what we're going to do. So we have to listen without judgment. We can't say, you're not thinking of suicide, are you? Which, by the way, people do all the time because we get scared. We don't want them to be thinking about it because then we have a whole set of events that we might have to do. But the truth is 90% of people who actually make a suicide attempt do not die by suicide. About 12 million people seriously thought about suicide last year. But the likelihood that they would die by suicide is very slim. Just over 48,000 people died. So 12 million, 48,000. I always ask people, do you have a patient that talks about suicide all the time, but you're not worried about them? And do you have a patient that doesn't talk about suicide and you're worried about them all the time? Trust your gut. Open the door and let them know that you're not there to judge them. You want to understand what they're thinking and feeling, whether they have a plan, what's leading them in their mind to want to die by suicide. Broaden their thinking and de-stress them so that they can come up with alternative strategies, both for managing ideation so they don't act on it. That's what the safety plan does. So hope you're all trained in how to develop a safety plan, but that's what also the other therapies do. Let them know, they feel terrible, but there are things together you can do to help them feel better. Think about, treatment, including, do you have a good alliance with this person? Are they doing what you've agreed they will do? Are they taking their medicine? Are they having side effects? Are they on enough medication? Of the third of the people who were in treatment at the time of their death, some of them were on medication. Most of them were under medicated. So we're not reaching people to begin with, but when we do, we're not giving them full treatment. Mobilize social supports, get their family involved. If their family is toxic, get whoever is in their life that can be an emergency contact involved. And not just for emergencies. I get a release for emergencies in the first session, so I don't have to worry about who I'm going to call if they go into crisis. See if they will engage in treatment and assessment. See if they need to go in the hospital. There are more and more crisis respite centers, thanks to the 988 bill. There's a crisis system bill that went along with it. So we'll have more places as clinicians to send people where they can de-stress and reintegrate and then go home. What are the plans? What's the hopes and aspirations for the future? I think I pretty much said this. If you think someone's an immediate risk, that's a time you can call 988 and they will help. You can even put the patient on the phone and they will help you figure out if this person needs mobile crisis or if this person needs police intervention. 80% of people who call 988 feel better by the end of the call. Of the 20% left, 17 or 18%, you get mobile crisis in there, they don't end up in the hospital. About 2% of people, actually, they end up calling the police. Even though everybody thinks you're going to call the police if you call them, they don't. It's not necessary. So now I want to get back to mental health and tending to your mental health. So I'm going to take a breath because that's a good way to tend to your mental health. Okay. First thing I want to talk about is resilience. And by the way, resilience is something that can be learned. Resilience is what? The ability to bounce back, right? We all have what we like to call a coping reservoir. Think about it as, well, don't think about it as the Hoover Dam because they're running out of water there, but think about your reservoir. How do you know when you're feeling depleted and when you're feeling refilled? So we all have this coping reservoir and we need to keep it filled because little by little, drip by drip, we're losing water from our reservoir. Maybe we didn't get sleep. Maybe we got rejected. Maybe we made a big mistake and we feel humiliated. Maybe we lost somebody. Maybe trauma was, resurgence. Maybe you just have too much going on. We're all sitting here at 6:30, 7:30 at night, still working. I know we all work late anyway because of our practice, but drip by drip, you're losing resilience. And so we have to pay attention to increasing and maintaining our resilience, sleep, exercise, doing things and being with people that make us feel good, staying away from people that are toxic for us, processing conflict, building our social connections, and therapy and treatment when it's needed. So all these things can help us maintain our reservoir, and we need to be tuned in to when our reservoir is not full. Think for yourself, what drains your reservoir? And then what's the counter activity that you can engage in to help you feel better? Some of the individual factors that relate to and protect are having a positive personal regard. If you feel good about yourself, you have a sense of pride, a racial or ethnic identity, you're proud about being a man, a woman, a non-binary person, that goes a long way. Having a sense of purpose. So there are times in our lives where we might start thinking we don't have a purpose anymore. Like I'm getting close to, like, people are asking me when I'm going to retire. I can't imagine it because I don't know what I would do. So I have to start thinking about that, because eventually I'm 66, eventually, maybe when I'm 90, I will have to, do something else. Emphasize the things you like about yourself. Understand that there is racial discrimination if you're from an underrepresented population. Understanding that there's discrimination and having a strong racial identity means you won't try not to personalize it so that it's not beating on you every day. And then, of course, social support. I'm going to end with just a few tips for engaging in self-care. I've already mentioned attend to the basics, but how many of us have gone through the day and not drank any water? Oh, that would be me today. How many of us have gone to sleep too late? Oh, that's me, because I go to sleep way too late. When taking care of what we eat and exercise. Find out, this may sound very basic to you, but it's really serious. Find out what works for you and build a repertoire of things that work for you, because sometimes yoga works, sometimes it doesn't. Sometimes watching a happy movie works better than going for a run. So you need a repertoire of things that you can do. Also, sometimes, like I broke my legs. Suddenly, I'm a big walker. I couldn't walk anymore. So I had to have other things in my repertoire that I could do when I was off my foot for 6 weeks. We don't want to be unidimensional. Think about what you can control and you can't control. And if you can't control it, don't worry about it. You can control your reaction to it. You can control what you do about it, how you feel about it. When I take the subway in the morning, I swipe my card. And then if I'm late, I'm late. If I know that I have something that I have to be at, I leave an hour or two early because I know the train is out of my control and something could happen. But I don't start worrying. Like, I literally don't sit on the train and worry, am I going to get there? Am I going to get there? Am I going to be on time? Because I've done what I can do. Don't worry, I have a lot of faults. I'm using this as an example, but develop and maintain a self-care plan, things that you do to keep self, and favor progress over perfection. The statement, perfection is the enemy of good. Have an accountability buddy. And I'm not just talking about a friend, but professionally, somebody that you can talk about your work with, that you can check in with, you can learn from. Get together with friends and peers and have honest conversations. Relax with people, maintain those connections, even sometimes when you don't feel like it. Attend to your physical, emotional, spiritual, and social environment. Keep the long view. Try not to get stuck on what's happening today. And have a sense of humor and curiosity. It goes a long way. And also when we smile, it actually changes our mood to be more positive. And again, reach out to a mental health professional. We are them if, we need them too. This is not very visible, but the point is we need to attend to our mind, our body, our soul, and our surroundings. So things like, for your mind, having a daily routine, setting goals each day. During COVID, I started tweeting out daily goals. And it turns out it helps other people too. Not that they have my goals, because as someone told me, it reminds me that I should do that. So I set 3 goals every day. And then if I do more, great. But I have intention in my day. People practice mindfulness, gratitude, read a book, whatever works for you. And acknowledge something good you did. Journal. Somehow express your feelings. For your body, we talked about exercise. Breathing, very portable. Take 3 breaths, takes 36 seconds. In for 4 count, hold for 4 count, let it out for 4 count. Nobody even has to know you're doing it. Your soul, ask for help, donate to a cause, go on an AFSP out of the darkness walk. Reach out to someone who needs you. Altruism goes a long way for filling our souls. And then, have a place where you feel comfortable. make your space comfortable. Show something that makes you smile. I've recently learned that those little kitschy statements that people have all over their house, and I was like, oh no, well, it turns out they're really nice. And just one little statement in your house or something you like can just put a smile on your face. So there's so many things we can do to take care of ourselves. And it sounds basic, but we forget sometimes. So I hope that something that I've just talked about resonated for you, and I'd like to open it up for questions.
Well, thank you so much, Jill. That was a wonderful presentation. Thanks, for being here and for talking with us. We do have a couple of questions in the chat. So I'll pose those first, and then if folks have questions, please pipe up. Is there an increase in child and adolescent suicide? Does social media or gaming contribute to that?
That's a big question, and it's a question on everyone's mind. So if we're talking about suicide deaths, depending on the age. So when you see the statistics, they often will say 10 to 24-year-olds. So I want to clarify, suicide happens, but it's extremely rare up to the age of 15. It does happen. The rates are a little bit higher from 15 to 19. But they don't go up as much until about 19. And that's when they start rising more dramatically. And they continue to go up all the way to older age. And in fact, older people are at higher risk. Kids are at the lowest risk. Any death is something we want to prevent. Any life there's value in each person. So when I talk about statistics, please understand that I think, one suicide is too many, but like heart disease and diabetes and cancer, we can't prevent them all, and they happen. And 50% of psychiatrists have had at least one suicide death of one of their patients. So we also have to deal with that and take care of ourselves when that happens. But back to kids. So they're the lower risk group, but even there, it depends, like I just said, on age and also on gender. Boys still 3 to 4 times more often die by suicide than girls, even at young ages. Race. So this is the one area where children of color, particularly Black and African American children, actually have a slightly higher rate of suicide, and it's been growing. We don't know if that's because the data are changing, because people are more likely to report a suicide than they were before, or what's leading to that. But kids are still the relatively low risk group. So if you see a kid talking about it, take it seriously, because it's really unusual. If they've made an attempt, you want to monitor them even more closely. Check out their risk factors and keep the door open for a conversation. Let them know that you're comfortable hearing what they have to say and talking about it. In terms of social media, we're all grappling with this. We all think about the websites that tell people how to kill themselves and some bullying, which apparently they're not calling it bullying anymore, but things that happen on social media. But the truth is, most material on social media is actually quite positive. Kids use it to get information. Kids use it to develop friendships, get support. So we don't want to throw out the baby with the bathwater. We want to help educate kids to basically do things that make them feel good and avoid things that make them feel terrible. So help educate them about how to use the web, help parents have an open conversation with their kids and know what they're doing, so that if they see they're on negative websites, check in with them, because that's not a good sign, and have that conversation. But also understand that there are kids, for instance, the LGBTQ community, where they have developed very deep friendships online that support them while they're having struggles in their current environment and daily life. And I worked with a patient, a 20-year-old, who actually had made a terrible suicide attempt It turns out he probably had Addison's disease, and when he got cortisol, all that went away, and he was very excited because puberty started coming back. And that was the first thing I did, was get him to have a checkup because I could see something was wrong. But he had this online community where when his computer broke, they all chipped in and bought him a new computer so that he could be part of the group. So my caution is that there's a lot of good online, but it's about learning what's safe and helpful and what's not. The American Psychological Association just came out with some excellent guidelines for social media, and I recommend that everybody take a look at them. They're published, they're available online. So I hope I answered all aspects of that question.
I think so. Another question is, suicide increased with higher education?
Well, it's a funny thing. First of all, it cuts across all groups. So lower education, higher education. But so it's not one or the other. There are people with higher education who are at increased risk and people at lower education. But when we're talking about education, you have to remember, onset of most mental health conditions is in the early to mid-teens. Those kids struggle with school. They may not even graduate school. If they do, they may have difficulty functioning. And then there's downward drift, because if they're not treated, and remember the average time to treatment for psychosis for a kid is 2 years. So it's very hard to look at education in and of itself. And of course, there's no one factor that's going to increase or decrease suicide. So I think that doesn't really, it's not like a marker, and it's also not something you're going to intervene with, except for a kid who hasn't been able to go to school, and you can help build their sense of identity, their competency, their sense of purpose, which, by the way, is true with older people. Some of the data, we conflate income and education, but mental health, having a mental health condition is really in that mix. So unfortunately, suicide cuts across all groups, all levels of education. And to me, that's a way, it's like the saying artists are more likely to, it has to do with creativity. Most of the artists who have mental health conditions can't function when they're in the throes of an episode. And in fact, when they're treated and feel better is when they actually do their art or their writing or whatever they're doing. So, we want to kind of romanticize it, but it's not very romantic.
Thank you. Anybody else have questions, comments, thoughts about the subject, about the lecture? I'll just throw it open to anybody, and if you you want to just unmute yourself and ask the question, that would be great.
I do see a question here about most people dying by suicide being under-medicated, and that's true. Remember, 90% have a mental health condition, though they may not know it. That's why public education is important. Of the third that are in treatment, and then a smaller portion are actually medicated, those that are medicated are most likely to be under-medicated. There was a paper by Maria Okendo that documented that.
I'd like to bring up a point. In the biggest situation I had with my patients, I'm retired now for 5 years, but I had a very active family practice. Referring patients to a psychiatrist, the reimbursements were so horrible for psychiatrists, they couldn't afford to participate. And the patients couldn't afford the non-participating rate. And I tried to address this when I was president and tried to have a rally and address the fact that Maryland's one of the poorest reimbursed financially, physicians poorest reimbursed in the country, ranking, I think they looked at 314 major cities across the United States, and we were like, all three of the locations they looked at in our area were in the 300s. Somehow or the other, the only way this thing is resolved is by getting patient support, and patients don't feel that physicians are um, are in any financial distress. But believe me, in pediatrics and family practice, and I'm sure in psychiatry, they're having difficulty dealing with the increased costs of having to run a practice. Hence, there's no longer anyone opening up private practices anymore. An individual, when they come out of medical school, they're looking for some large group where they're just going to be a a member of the group. And I think that diminishes the emotional connection between the physician and the patient. I think that solo practitioners, I know that there's something that's added there when it's their practice and their patients. I'll stop there.
Yeah, I mean, access to mental health care, 100% of our states are under-resourced for mental health care. And we have a whole advocacy arm at the American Foundation for Suicide Prevention. And I encourage you to go to afsp.org, and we have an advocacy center. And these are the kinds of things that we advocate for. And we're actually working now with, there was an open statement for CMS about a commentary on their new guidance, where they are talking about the lack of resources and also adding, hopefully, some payments and codes for some of the work in suicide in particular that's not really reimbursable, like a follow-up call, like a safety plan, doing a suicide assessment. There's no reimbursement for those things. So they are actually looking to start adding those. But become an advocate. You can look on our website. It's simple. You just put in your name and address, and if you don't get flooded with emails, if we're advocating for a specific mental health issue, like 988, that came from our advocates, all flooding them with emails. So we send you an email, state or federal, depending on and you can adapt it. You can add to it if you want. Put your personal touch. I do often. And then you just click a button and it goes to all your legislators, and it makes a difference. It makes
Thank you.
difference.
Thank you.
I have to say, I think that's an excellent point. And access to care as a barrier. I mean, we just have to figure out ways to knock it down.
Yeah, I always took insurance, which meant that nobody ever refers to me for a patient who can actually fully pay, because they know I take insurance, so they refer insurance. But it's painful. I mean, my phone, I have very limited hours, but my phone is ringing off the hook. I can't even call people back because I get so many calls of people looking for treatment.
Yes. So I see a hand up. James Williams, do you want to unmute and ask your question or make your comment?
Yeah, sure. Thanks very much. I appreciate that. Really spot on. I think your comments were fabulous. I'll share with the group that my son died in March. He's 25 and he was in a MBA program. And I think your comments were just perfect to say that he had no intention to die that night, but it happened. And he certainly had the resources. But his disease was just, I think overwhelming. And for whatever reason, we're still trying to figure that out. But I thought your insights were fabulous. So I hope the rest of you can really put that into context to the patients that we're caring, and really for our loved ones, most importantly.
Yeah.
The second thing I'd like to share is that I agree the resources are really challenging. I work in the emergency department, and we are the safety net for the community. So if anybody makes a suicide gesture comment, oftentimes police bring them in. And fortunately, we work in some places where the police have been educated about how to deal with that. And that's also an important outreach, because if the police are not, then that's when really tragic events can occur, if the police perhaps don't understand what the individual is going through. Again, your comment about the person not having the rational resources to make decision makings at that time of crisis, that was just spot on. So then the last thing I again want to thank you and agree with you to say, please be an advocate. Jim York, current president of MedChi, he's done a great job, I think, of highlighting this issue. and I applaud that also. Reach out to therapists in the community. It does span all socioeconomic areas, but certainly the people who are less financially endowed, their ability to seek help is even more constrained. The parents can't take off from work or for whatever reason because of the finances. So this is where the legislative component gets in to say, look, this is really a problem. We need to have some resources. It is a challenge, and I think that the therapists really are going to be essential because the physicians and other traditional means simply are not funded and are not there relative. So it's supply demand mismatch. So that's it. But again, thanks. This is something that normally I may not attend, but I think your comments are really spot on, both for us being advocates for patients, but also for ourselves. So thank you so much.
Thank you. I'm so sorry for your loss. And please know that if you've never connected with AFSP, you are definitely not alone. And it's the most amazing community of people. And you just go to a walk and you'll see it. But we have all kinds of things. I want to say that one of the ways that we advocate is, so for instance, we have an advocacy day. We pick 3 or 4 asks. That's what we focus on that day. We visit as many congressional offices as we can. We live stream the events to train people up. So this year we advocated for mental health centers in schools, more community service, veteran service providers to help them get services, and 988, and also funding research. So it's not just saying we need more providers. We did submit comments to the CMS guidance, and they are actually the guidance says that they're going to pay master's level licensed professionals, which will open up tremendously. And then hopefully they'll get more and more education about suicide prevention. We do a lot of work in that space. We partner with Psych Congress, for instance. But I appreciate that. And I also want to say it's really important when you meet someone to ask if they've lost someone to suicide. It's a shame to find that out 6 months into treatment about something that's so powerful in a person's life. Thank you so much for having us here to talk about this topic, which is just so important.
Yes, thank you. All right, good night.
Good night.
Thanks very much. Good night, everyone.